the fact that mammograms, that in these well-educated areas, wealthy areas, that people are insured, are they not finding it? Is it late stage because they actually are going and having their mammograms, but the mammograms just aren't catching it?
Well, as you well know, there's the breast density issue. And
yeah.
Connecticut...
It's my issue.
It's your issue. It's my issue, too. Connecticut was the first state to have legislation passed that required that a woman was told if she had dense breast tissue. We now have federal legislation pending. So we hope all our legislators will sign on to that and pass that legislation so all women are told if they have dense breast tissue. If a woman has over 50% dense breast tissue, there's a 40% chance that her breast cancer will be missed on a mammogram. So she needs an ultrasound or an MRI.
And yet there was just a report out, I'm sure you saw it, it came out 5 o'clock yesterday in the New York Times, saying from the Annals of Internal Medicine that of that 45% of women who have dense breasts in America, who the mammogram just isn't working for, that maybe only half of them really need that extra ultrasound. Now, I don't know how they plan on actually determining, like, if you're one of the ones that get that extra test, and what if you don't fit into their standard risk factors? Then you just, what, you just wait and hope for the best? I mean, I'm not going to treat my health that way.
And neither am I. And you know, some of this stuff makes me personally so angry.
Oh, yeah.
It really makes me furious, because what about the half of those women? If in fact, because you know, one study's done today, another's done next year, they may have different findings. What about half those women? Are we saying that their lives don't matter? That they should be diagnosed at a late stage?
I'm there on the steps with Ann now on Capitol Hill, and we go from office to office, from senators to Congress people, and they sit and they listen to you, and I sometimes wonder, what could possibly be the rationale to not say, give it to me, I'll sign right now, when it doesn't cost anybody any money? We're not mandating medicine. We're simply saying this is information that was garnered through a medical exam of a woman, and it's about her body, and it's a life and death piece of information. Just give it to her. That's it, right? That's really all the bill does.
That's all it does, is give her the information she needs to make an informed decision about her breast health. It's infuriating, and it's politics at the end of the day. I really believe that, you know, there's a lot of politics in our healthcare nowadays, and we all know that. I mean, that's just the state of where we are right now.
But where is the line drawn between politics and just simple moral, just doing what's morally and ethically right according to the code of the American Medical Association? We shall do no harm.
Yes.
That is the code that every doctor has lived by in this country for, you know, decades. We shall do no harm. And by running a test on a woman, a diagnostic test, finding out that that test doesn't work for her and then not telling her, to me that's doing that woman harm.
Yes, it is. It honestly is, and it needs to change, because women are dying unnecessarily.
Yeah.
And that's the bottom line. And it needs to change, and I think we really need to get women educated about the issue so that they will speak up, and together we can collectively have our voices heard. Because, you know, I go up there and who am I? And even you with your celebrity, you felt as though, you know, I mean...
Like I had to get up and do a tap dance in order to get a politician to say, okay, I get it.
I'll do it.
You would have died without this other test. I mean, that was my bottom line.
Yeah.
Is that if I hadn't had that test, which no doctor told me to get, no radiologist told me to get, Like, we need to tell women if they have dense breast tissue. It's interesting when I think about you being up there with me and all the other women who are really out there on the front lines of this fight, trying to protect every woman in this country. Most of them had been touched in some way by breast cancer. And that's true for you too, right?
It is. It is. I was touched at a very young age. When I was 9 months old, my mother died of breast cancer. My brother was 2, and she was 4 months pregnant. And
got diagnosed with a young child and during pregnancy?
Yeah. I was 5 months old, and this was, 50-something years ago. And, in those days, they told my dad there was nothing we could do. And I felt robbed most of my childhood. I'll tell you, I really felt robbed. And it wasn't until I was older and I decided that I needed to make a career, I guess, out of, helping women with this disease. And the more I learned, the more important it becomes to me. And then actually my dad remarried when I was 18, and he died of ALS 3 years after that. My stepmother got breast cancer. And then she had a recurrence, and I did her hospice care, and we lost her in 2003. So, it robs people. You're living in an area here in Greenwich, Connecticut, where I hear about young women every day with young children.
Yes, and that's why younger and younger. This used to be a disease of women over 60, certainly women over 50. And I hear from women every day in their 20s and their 30s that are battling breast cancer.
One thing we learned at Komen, Connecticut is that young survivors, as we call them, young fighters, don't really have support they need, because a lot of the support is designed for women that are older. So we've actually started a private, closed Facebook page where we have about 75 women in Connecticut who are under 40, and they share their experiences, and they also ask questions of one another. So I just started such and such chemo, and this is happening. Anyone else out there have this happen? And within 10 minutes, there's 6 or 7 answers to that. We've also started a face-to-face support group for women actively in treatment in our offices in Farmington, Connecticut. And we get 15 or 20 women. And they come in and they all have their scarves on and they tell their stories if they have babies. There was a woman, you were kind enough to come to our Race for the Cure in Westport a few weeks ago. A young boy won the t-shirt contest that we had. His mother, he was a twin, his mother was diagnosed when she was pregnant with him. So, we're seeing more and more of this. 24% of the breast cancers in Connecticut are diagnosed in women under 50. 24%. So if the U.S. Preventative Task Force and some of these other organizations want to come out and say that women under 40 don't need to get screened, that's 1 in 4.
So what about the task force that was put together that recently recommended that we push the age back and not start mammograms until 50, and that we do them every 2 years, not every year? There wasn't one breast cancer surgeon, not one oncologist, not one radiologist on that task force, not one survivor.
That's correct. That's correct. And while I fully respect them and their professions as physicians, we vehemently disagree with their recommendations of starting mammograms at age 50. As I said to you a moment ago, 24% of breast cancers occur in women under the age of 50 in Connecticut. What about those women? If 3,000 women are diagnosed this year in Connecticut, which is how many will be, newly So 750 women in Connecticut, Joan, we're not talking across the United States, in Connecticut would not be diagnosed. What do you say to those women? In Massachusetts, 7,000 women will be diagnosed with breast cancer this year. 7,000.
It's just
What do you say to
the
those?
numbers are overwhelming, which is why, organizations like Komen and others are pushing so hard to try to change laws and protect women. Two other bills, and besides breast density, that I want women to understand that you can speak to, I believe. Oral parity. They're going to start hearing about oral parity. What is that?
Oral parity, we actually had legislation passed in Connecticut in 2011, and Komen, Connecticut had it introduced. So what was happening was women were beginning to get their chemotherapy in pill form. So they were taking their anti-cancer medications orally. And most insurance policies have 3 separate categories for prescription drug coverage. Right? You have generic, and then you usually have formulary A and a formulary B. Well, they were taking these oral anti-cancer medications outside those 3 categories.
So they didn't have to pay.
Well, they didn't have to pay as much. So what it was really shifting the cost back to the patient, bottom line.
Yeah.
Is what it was. So normally a generic drug might have a $10 copay, formulary B might have $25 and $40. These anti-cancers, they were putting a percentage on, so 25%. Well, some chemos, I don't know if you know how much your chemo costs, but they can be $5,000-$6,000 a treatment.
Oh yeah.
I
And
know
more.
I know women who used up their children's college savings to pay for their oral chemo. So the bill we had passed in Connecticut and the bill that we're trying to get passed across the country, and Komen is working on in other parts of the United States, is that insurance companies need to cover oral anti-cancer medications at the same out-of-pocket cost that they cover the infusion. So it's actually lower cost to have it through oral method.
Yeah.
Right? Because you're not going to the doctor, you don't have the port, you don't have the nursing, so on and so forth.
Not to mention, as I understand it, there are some new drugs that are coming out, and they're only coming out in the oral form, not in the infusion form.
That's correct. We're going to see, I think, more and more. And someday it's my belief that we'll probably see almost all anti-cancer medications in oral form. There's a high risk of infection.
When you're doing infusion.
Women destroy their veins.
Yeah.
They have to put in ports. I mean, port is an open area of a, highly susceptible to infection. So as that becomes more and more prevalent, we need to change the laws so that women are only paying, or men, because we know men get breast cancer too, at the same rate of out-of-pocket that they would pay if they were going to an infusion center and getting it.
And now we're getting into the area of cost, and my heart just goes out to all the people that I hear from all the time that are losing their houses, that are in incredible debt, that have gone into bankruptcy. And I've come to learn that most bankruptcy is associated with medical debt. So can you tell us about the medical debt relief bill?
I haven't done a lot of work on the medical debt relief. I know it is, the purpose of it is to separate out that debt.
From consumer debt and medical debt.
Right.
It's not paying your Macy's bill is a lot different than needing chemotherapy and having to pay it or die.
Right. And if you have a household income, if you have a household income, $80,000, $90,000, $100,000 a year, if you've got $200,000 in healthcare debt, which is easy to rack up, very easy, you've got another mortgage. You've got another large payment every month that you can't afford. So what do? You turn to bankruptcy court. And then your credit's destroyed. In some cases, your livelihood is destroyed. There are employers now who run background checks on credit. So if you've gone through a bankruptcy, you've jeopardized a lot of different, avenues to happiness in your life. So it should not be that we're forcing people into bankruptcy for what should be a basic human right, which is health care.
You know, one thing I know for sure is that people do want to help. I mean, they show up at all the races and they're donating money. And I mean, I forget how many millions of dollars have been donated by Komen to research. You know that number.
2.5 billion.
2.5 billion. And this is why we're getting the advancements that we are in breast cancer research. But there's so much to be done, even on the legal level in Washington. How can they help? I mean, is it helpful to write your senator?
It's absolutely helpful. They can go to our website, Komen.org, and they can click on a call to action, and they can get a form letter that they can send to their senator, and it makes a difference. They can also get a phone number to call their senator's office. They're not going to reach their senator or their U.S. representative.
But it'll be registered.
But it's registered as so-and-so called on such and such a bill to either oppose or support. And that is, tallied. And the ones that get the greatest amount of support or opposition are usually the ones that, float to the top and get action. So
never underestimate the power of the individual voice.
Right. What did Margaret Mead say about a small group of people making a big difference? So there's a lot that people can do. As you said, they can donate. They can pay attention to their own breast health and be their own best advocate. That is so very important. And whatever they can do to donate. I mean, I know it sounds like, well, how far does $1 go? $1 goes really far. When you're giving someone a ride to treatment, or you're helping to educate people, or you're helping somebody get a mammogram. I have folks who will donate $12.50 a month, $12.50 a month, will buy one mammogram a year.
So it's one woman whose life you may save.
Yes.
It's all about keeping everybody alive.